Hi, everyone. This is E. David Crawford. I've had the opportunity to attend advisory boards and other sponsored meetings where presentations were made by the medical directors and medical affairs staff of a number of different pharmaceutical and device industries. I have found these very concise, informative, and usually pretty balanced. Up until now, there has not been a forum to house these presentations, and Grand Rounds in Urology is launching a new exclusive feature called Industry Perspective for GRU. Our goal is to have a large library of these less than 10-minute balanced presentations. Today's presentation is by Dr. Dan Shoskes, formerly from the Cleveland Clinic, and now the medical director for urology of Exact Sciences. His topic is the molecular marker Oncotype DX.
Thank you for the opportunity to present on the Oncotype DX Genomic Prostate Score Assay, also known as GPS. Today, I'd like to give a brief overview of the rationale, development, validation, and practical uses for the test. Here are my disclosures. Of note, I am a full-time employee of Exact Sciences, and for additional information, please go to oncotypeiq.com. So why are we interested in genomics in prostate cancer? Prostate cancer is a genetic disease. These abnormal genes can lead to aberrant gene expression, which causes abnormal and unregulated cell growth. This unregulated growth results in a clinical growth in the prostate, which can be palpated, altered appearance on MRI, a breakdown of the prostate blood barrier, leading to elevated blood levels of PSA, and in the biopsy, a disordered gland appearance on histology, which is the basis of the Gleason score. The question is, do these clinical features completely capture the prognosis of the patient, or does looking at the gene expression directly give further information? To answer these questions, Klein and colleagues started with 727 prostate-specific candidate genes. They looked at radical prostatectomy specimens, and importantly, they addressed heterogeneity and multifocality by only looking at genes that predicted recurrence in both the primary and the highest Gleason patterns, and this winnowed it down to 288 genes. In the second development study, genes were further screened for reliability that they could be recovered from prostate needle biopsy tissue, and for prognosis of other endpoints such as death from prostate cancer, adverse pathology, and biochemical recurrence. And this gave us a total of 17 genes. And these are the genes in the assay. You can see they're in 4 pathways specific to prostate cancer, plus 5 reference genes. So, how predictive are they? Well, it has been shown now that the GPS assay is an independent predictor of metastasis and prostate cancer death within 10 years of radical prostatectomy. While it is an independent predictor, you get a more refined prognosis by combining it with NCCN risk groups. Consistently and importantly, no patient with a GPS result under 20 had metastasis or died from prostate cancer within 10 years. And as you can see, the GPS result goes from 0 to 100, with 0 being the least aggressive and 100 the most aggressive. Recently, Brooks and colleagues saw that the GPS assay was predictive of distant mets and prostate cancer-specific mortality even out to 20 years. The other key predictor in the assay is the prognosis for adverse pathology. Brooks additionally found that adverse pathology, as defined by either PT3 disease or higher and Gleason grade group 3 or higher, was a very strong predictor, even over 20 years, for distant metastasis and prostate cancer mortality. Importantly, this was a cohort that's representative of an active surveillance population. Here you can see how GPS can help predict the probability of adverse pathology. Again, while it's an independent predictor, if we combine the number with the NCCN risk, we get a more refined and accurate predictor. Even in the era of routine use of MRI, GPS plus the Gleason score was fully predictive for adverse pathology, and adding highest PIRAT score from the MRI did not give any additional predictive value. So the answer to the question, does genomic scoring give additional information to clinical and pathologic features? The answer is yes. Biology trumps histology. Looking at gene expression through GPS gives further predictive information for adverse pathology, biochemical failure, metastasis, and prostate cancer-specific mortality. So how do we use this practically? For low-risk patients, those in the very low, and favorable intermediate risk, typically the discussion is between surveillance or definitive therapy. Here, the GPS result can help with shared clinical decision-making by further refining the risk of adverse pathology, metastasis, and death. Indeed, several studies have shown that adding GPS to the discussion consistently leads to higher use of active surveillance, appropriately in low-risk patients. What about the higher-risk patients? Well, in these men, the discussion is typically not active surveillance versus treatment. They're going to have treatment, but within guidelines, there can be a wide range of treatments and whether it is single modality or multimodality. In this study, looking at unfavorable intermediate risk patients and biochemical recurrence after radical prostatectomy, a GPS cut point of 40 divided these men into two groups. Under 40, they behaved like a favorable group, and over 40, they behaved like NCCN high-risk patients. And this is a group that might benefit from treatment intensification. So in summary, the Oncotype GS GPS assay provides meaningful and actionable information on the biologic potential of prostate cancer, independent of clinical, pathologic, and radiographic data. For your lower risk patients, it can help inform shared decision-making for active surveillance versus immediate therapy with curative intent. And for higher risk patients, it can help inform the decision for treatment intensification. Thank you very much.